Dear friends, greetings. Welcome to New Forever Eskool Migraine Basics Module 2. Let us start with understanding migraine pathophysiology, neurovascular theory. As you know, the cerebral cortex of migraine patient is hyperexcitable. So whenever there is a trigger, this trigger leads to cortical spread depression. Cortical spreading depression is nothing but waves of depolarization, neuronal excitation and depression. This cortical spreading depression leads to dilatation and contraction of blood vessel, which in turn leads to activation of trigeminal nerve, which is the fifth cranial nerve. Now this activated trigeminal nerve leads to release of vasoactive peptides like substance P, neurokinin A and CGRP, calcitonin gene-related protein. These chemicals are nothing but inflammatory mediators which leads to inflammation and further vasodilatation. This cascade further leads to reverse flow of impulse to brainstem, thalamus and cortex, and then activation of first order neuron, which is called peripheral sensitization. This peripheral sensitization further leads to activation of second order neuron at CNS and excitation of nociceptors. Nociceptors are pain receptors present in the CNS, central nervous system. And this all leads to throbbing pain, pulsating sensation, nausea, photophobia and phonophobia. After understanding the pathophysiology, let us see stages of migraine. Broadly, there are 4 stages. Predrome, which is also known as premonitory phase, aura, headache and postdrome. Predrome, which occurs 1 to 2 days prior to the attack, where patient feels fatigue, cognitive difficulty, food craving, mood changes and sometimes anorexia. Anorexia is abnormal eating habits. Aura, on the other hand, is a warning signal which occurs just 1 to 2 hours before the attack. During aura, patient may have experienced scotoma or flashing of lights or paresthesia, that means numbness or tingling sensation, sometimes weakness and vertigo. Third phase is headache, which lasts for 4 to 72 hours, where patient feels throbbing pain with pulsating sensation, nausea, photophobia and phonophobia. The last phase is called postdrome, which is after the headache attack, which lasts for sometimes 4 to 12 hours after headache. Here, patient feels drained, exhausted, washed out, fatigue, or sometimes patient may feel fresh also. So let us see migraine management. Broadly, there are 3 ways to manage migraine: non-pharmacological, abortive therapy and prophylactic therapy. Non-pharmacological management includes lifestyle modification and identification and avoidance of trigger. Abortive therapy means acute therapy, that is relieving the intensity, reducing the intensity of attack. And there are 2 categories in abortive therapy: non-specific drugs like NSAID, painkillers or antiemetics, and specific to migraine like ergots, triptans and alkaloids. So for the prophylactic treatment is concerned, that is called preventive therapy, where broadly 3 class of drugs are used: beta blockers like propranolol, calcium channel blockers like flunarizine, and anti-epileptics like dialprox sodium and topiramate. So let us recap. We saw pathophysiology, neurovascular theory, hyperexcitable cortex of migraine patient, when triggered, it leads to cortex spreading depression, which leads to activation of trigeminal nerve, fifth cranial nerve, and in turn releases the vasoactive peptides. And these inflammatory mediators activate first, second, and third order neuron, which leads to activation of nociceptor or pain receptor, and ultimately it leads to headache. There are 4 stages: predrome, aura, headache, and postdrome. Prodrome occurs 1 to 2 days prior to attack, where patient feels fatigue, mood change, and craving for food. Aura is a warning signal which occurs just 1 to 2 hours before attack, where patient feels flashing of lights or paresthesia, that is numbness or tingling sensation. Headache phase lasts for around 4 to 72 hours, and patient feels throbbing pain with pulsating sensation, with nausea, photophobia, and phonophobia. After the attack comes postdrome, which lasts up to 4 to 12 hours, and patient feels fatigue, drained, and sometimes fresh also. So for the management is concerned, there are 3 ways. Non-pharmacological management include lifestyle modification, trigger avoidance, abortive therapy, that is acute therapy, includes NSAIDs, triptans, and ergots, and prophylactic or preventive therapy includes beta blockers and calcium channel blocker. Thank you.